are you?
Hello, I just needed to unmute myself. How are you?
I'm doing well. How are things going for you?
Good. It's a very interesting concept.
Mm-hmm. Hi, Bertina.
Hey guys.
I'm just checking the Zoom settings before we get started.
And try to see if I can share my screen.
Yes. Also going to make sure you are co-host so that everything should be all set.
Okay.
Wonderful. Yes, I can.
So you can see my slides, right?
Yes. Yep, looks perfect. We're going to give it, let me check the timing real quick. A few more minutes. We'll get started at the 45. Thanks for your patience, everyone. We'll be getting started in about a minute, just waiting for everyone to trickle in for our official start at 5:45 EST. Awesome, let's go ahead and get started. Hello, everyone. So great to see you again. So really been wonderful to see all of your faces through multiple sessions throughout the day and hopefully tomorrow as well. My name is Chinmay. I'm a Synapse team member, and I specifically lead the events committee within Columbia Synapse. And it is my pleasure to introduce to you today our speaker, Dr. Veronica Logovinsky. I'm going to briefly tell you a little bit more about Dr. Logovinsky's background and current work, and then pass it over to learn more about the fascinating research she's doing. So a little bit of background. Dr. Logovinsky received her BS degree in applied math from Yale University, a master's degree in chemical physics from Columbia, and a combined MD-PhD degree from the University of Pennsylvania. Her work in biophysics utilized highly resolved fluorescence laser spectroscopy to study interactions of porphyrins with proteins in biologically important enzymes and modeling behavior of proteins in complicated physiological systems. After she completed her MD-PhD program, Dr. Logovinsky underwent her residency in psychiatry at the Harvard University School of Medicine and is a board-certified psychiatrist with clinical experience in neuropsychiatric disorders. For the past 19 years, she's worked in the pharmaceutical industry and has focused primarily on the neuroscience therapeutic area and has also led several large programs in Alzheimer's disease. She's particularly interested in innovative clinical trial design elements, including novel clinical outcomes. Within ISI, she has led the efforts on the development of ADCOMS, which is a clinical outcome assessment tool for the early stages of AD. She's also presented this work at a variety of different conferences and forums, and currently serves as co-chair of the ADNI PPSB Clinical Endpoints Working Group, where representatives of multiple pharmaceutical companies combine their efforts to study behavior of clinical tools, specifically in the pre-symptomatic stages of Alzheimer's disease. And her workshop today will be focusing on, as you can see on the intro slide, focusing on understanding schizophrenia. So without further ado, I pass it over to you, Dr. Logovinsky. Thank you.
Thank you very much. That was a very kind introduction. I need to make a bit of an update to it. I'm no longer at ASI. I am now with a company that is led by Dr. Luthman, the company that you heard about, Lundbeck. And I have shifted my focus from neurodegenerative disorders and Alzheimer's disease specifically to a variety of neuropsychiatric disorders, including some aspects of psychotic disorders and schizophrenia, and that's what I'm going to be talking about. So everything that you said is true, but then I've gone further, and that's where I am today. And in some ways, I'm sorry that I can't talk to you about some of the research that we're doing, because it's absolutely fascinating in terms of drug development. And in other ways, I am going to talk to you as a psychiatrist, which I think is hopefully quite helpful. So I'm a full-time employee of Lundbeck, but for the purposes of this discussion, I'm not representing Lundbeck in any way. I'm just representing my own experience and my own opinions about schizophrenia. So I wanted to start with just some basic concepts about schizophrenia. And when people, particularly psychiatrists, think about schizophrenia and the history of this disorder, they, of course, remember two psychiatrists. One is a German psychiatrist, Emil Kraepelin, and the other one is a Swiss psychiatrist, Paul Bleuler. So Kraepelin, who lived at the end of the 19th century, the beginning of the 20th century, of course, didn't have access to any of our modern technological tools. But fundamentally, he was a biological psychiatrist. He believed in psychiatric diseases being brain diseases, and being as biological as all the other diseases that we deal with are. He is considered to be the founder of modern scientific psychiatry, and he is the one who relied on his own observations and as much of this scientific methodology as he could at the time. So what did he have at his disposal? he had phenomenology or symptomatology. He was observing patients. He was observing patients living in mental asylums over time, and he would meticulously map symptoms to the time axis, to the progression of the disease. And he was hoping to get understanding of the biology of the brain diseases by studying patients, by studying symptoms. And he learned a lot, but unfortunately, it didn't really move him in the direction of understanding the biology. What he did at the time was he developed this framework, this cognitive framework of separating psychotic disorders into manic depressive disorder and what he called dementia precox. And dementia precox is what later became schizophrenia. Dementia precox is premature dementia. And he believed that those were sort of the two buckets of psychotic disorders. And with the manic depressive disorder, you had relapsing and remitting episodes, and you were able to go back to your normal functioning. And with dementia precox, you essentially had young people undergoing a dementing, a degenerative process. And I remember as a resident still arguing this question: is schizophrenia a dementing process or is it a neurodevelopmental process? And by today, we pretty much agree that it's a neurodevelopmental process, that something goes wrong during the development of the brain. Lawyer, living roughly at the same time, actually coined a variety of psychiatric terms, and schizophrenia is the term that is attributed to him. And he wrote a manuscript in 1911 on dementia precox or schizophrenia. So even at that time, he was talking about this family of diseases, not one disease, that he called schizophrenias. We'll talk more about this. So what's the diagnostic process for something that we call schizophrenia? Unfortunately, physical and laboratory exams are done generally to rule out psychotic disorders that are due to a medical condition or substance-induced psychosis, but are not really that helpful in diagnosing schizophrenia itself. They are there to exclude other reasons for psychotic symptoms. Imaging is not helpful either, even with all the variety of imaging that we have today. And the diagnosis is really commonly made on the basis of history and the mental status exam. And remember, Dr. Luthman was talking about all these wonderful biomarkers that are so important for the understanding of diseases and development of drugs. Well, unfortunately, we have no reliable biomarkers for diagnosis of schizophrenia and determining the severity of the disease. And that reflects the complexity of what we're dealing with. It is an excruciatingly complex and painful disorder. So what we do have are the formal diagnostic criteria for schizophrenia, and those are outlined in the Diagnostic and Statistical Manual version 5, and they include 2 or more of the symptoms that are listed on the slide, and one of the symptoms has to be either delusions or hallucinations or disorganized speech. And the other symptoms are disorganized behavior, and then negative symptoms, diminished motivation or emotional expression. And then the symptom or these at least 2 symptoms have to last for at least 1 month. There has to be evidence of declining functional abilities in work, relationship, self-care since the onset of the symptoms. And then the entire constellation of the signs of the disorder should last for at least 6 months. And there may be a prodromal sort of a stage where you don't have fully expressed symptoms, but you have some symptoms that are attenuated, that are weaker than what we see in full-fledged psychosis. Now, what's the problem with having this kind of a system of diagnosis? Well, um, you are people who deal with mental health, and probably many of you know that people experience delusions, hallucinations, and even disorganized speech in a variety of other disorders. For example, in Alzheimer's disease, with which I dealt for a long time, people have delusions, they have hallucinations, often visual, not auditory, as opposed to schizophrenia, where the predominant hallucinations are auditory. And they may have and do develop problems over time with speech. Um, but they have Alzheimer's disease. And we know that they have Alzheimer's disease because of some constellation of other symptoms, and because we actually can scan their brains today and can see amyloid accumulating in their brains. And that's what it takes to make the diagnosis of um, Alzheimer's disease. In schizophrenia, you don't have that. You have to rely on history and the mental state examination. But psychiatrists actually have become quite good at this. Um, so that same sort of issue with naming the core features of disease to be the positive symptoms, the psychotic symptoms, is expressed in how people look at schizophrenia in general and where we're looking in terms of schizophrenia today. So schizophrenia is much, much more, unfortunately, than hallucinations and delusions and speech disorganization that people think about when they think about schizophrenia. The symptoms are broad and complex, and that's probably fundamentally the reason why we have so much trouble with our understanding of this disease. So there are three buckets. There are positive symptoms, which are delusions, hallucinations, and all the things that I already talked about. Then there are negative symptoms. So in the positive symptoms category, you have symptoms where there is excess or distortion of normal functioning. And in the negative symptom category, you have decline or loss of normal functioning. So you have poverty of speech, you have lack of motivation, you have inability to experience pleasure, something that people call anhedonia, lack of desire to form relationship, inability to form relationships. You have diminished emotional expression. And then under the cognitive symptoms, which are very important and by some people are considered to be part of the key to this whole concept of schizophrenia. You have a variety of problems, including problems with attention and memory, executive functioning, planning, working memory, holding information online, um, processing speed, inappropriate affect, um, capacity to inhibit one's actions and one's emotions. And what I wanted again to stress to you is that people who suffer from schizophrenia suffer from a horrendous disorder. They are burdened by both these positive symptoms that are quite unpleasant. The delusions are often paranoid delusions. The hallucinations are often very critical. They really are telling people how bad they are. They're telling people how bad things are in general. They're very painful and negative symptoms that make people unable to function socially. So that when I was in residency, part of my residency had a mental health institution that has now been closed. And I was in residency in Boston, and the mental health hospital was one of those old and by that time dilapidated mental health hospitals. You would walk in and you would see people with schizophrenia who had suffered from the disorder for a long time. And by that time, they were kind of called the burned out schizophrenic patients. They'd be sitting there, they'd be quite blank, They would not be interacting with each other. There would be very little motivation to do anything. And just by looking at them, you could think that they were actually dementing. So what's the course of the disorder? You have a disorder that is a biological disorder with a strong genetic component. But the interesting thing is that the symptoms really don't come on. They don't become apparent until well into adolescence or early adulthood. You start out with most people being reasonably normally functioning people. And then you have a prodromal stage when you have the beginning of the symptoms. And then usually we consider the onset to take place with the onset of psychotic symptoms. And that, as I said, happens in adolescence or early adulthood. Then at that time, you don't have this burnout schizophrenia. You have people who are tormented by psychotic symptoms, who exhibit cognitive deficits, and often all of this is accompanied by a sense of unrest and anxiety and emotional components, what we call affective components, that make people sometimes misdiagnose schizophrenia for what's called schizoaffective disorder or bipolar disorder. And then what happens is that in the course of the disease itself, you have relapsing and remitting episodes, except that when people actually have an episode and the episode remits and people feel better, they don't go back to the functional level where they were prior to this episode. They go back to a lower functional level. And so as they go through these episodes, as they go through this psychotic and active stage of the disorder, they lose their functionality. And we already know that when people discontinue their treatments, they contribute to these relapses and they contribute to this deterioration. And we'll talk more about why they discontinue treatments and what kinds of treatments they discontinue. And eventually you come to this stage of relative plateau. That's that burnout stage where you have residual symptoms of the illness, and people have already quite declined functionally. And today they're not living in mental state institutions, mental health state institutions. They often end up, at least in the United States, living in some sort of boarding houses or just living on the streets. And continuing to suffer. And unfortunately, schizophrenia is also associated with early mortality, not just this horrendous morbidity of the disease. Well, we're now in the century of genetics. People have done lots and lots of genetic analyses. People have looked at the entire human genome. It has now become possible for us not only to decode the genome, but also to manipulate the genome. That's where all these genetic treatments are coming about. So what is the genetic component of schizophrenia? If you look on the left, you'll see a graph it's a bar graph with the indication of what we think the genetic component is depending on what kind of inheritance one has. So for monozygotic twins, if one of the monozygotic twins develops schizophrenia, the other twin has about roughly a 45% chance of developing schizophrenia. If you have two schizophrenic parents, the chance drops down to maybe 37% in this estimate. And so forth. There's a further substantial drop with dizygotic twins and so on. But the fact that the monozygotic twins have such a strong risk of inheriting the disease clearly tells us that this disorder has a very strong genetic component, but genetic the genetic component is not responsible for everything. It can't explain everything. This is not sort of a Mendelian type of monogenetic disorder. And when we look at the analyses that have been done, different kinds of genetic analysis, we see that hundreds to thousands of genetic loci have been implicated in the risk of schizophrenia. The last time I looked, it was an estimate of something like 8,500. So each one of these changes, and there are different kinds of changes. They may be SNPs, they may be different copy versions, they may be deletions or replications. Each one of these changes is contributing a little bit to this risk of schizophrenia. And it's very, very difficult for us to make sense out of this. So looking into genetics today doesn't really help us, unfortunately, that much to understand the underlying pathophysiology of schizophrenia. What we also know is that disorders with prominent psychotic symptoms, so that framework that Kraepelin was talking about, are actually genetically related, and they're significantly genetically related. So the psychotic disorders, schizophrenia, schizoaffective disorder, the psychotic bipolar disorder, they're kind of on a spectrum with a variety of similar but different in severity biological changes associated with these disorders. And finally, the really fascinating aspect of all of this is that among the first degree relatives of patients with psychotic disorders, right, only 1/3 in this particular study, but that's been shown many times, do not have a major psychiatric diagnosis. But the diagnosis does not have to be that of a psychotic spectrum disorder. It can be major depressive disorder, it can be drug abuse. So there's something in the way that we're categorizing these disorders on the basis of symptomatology that's just not quite right. But it's so very complicated to do it from the biological point of view. We haven't learned how to do that either. What is schizophrenia like in terms of the course of the disease? Unfortunately, and you see the results of one analysis that actually included 6,000+ patients. 62% of patients have a poor outcome. So they're the patients who really suffer from the disease and decline, deteriorate. And now you have people who live very difficult, very painful lives, and their lives are never normal. On the bright side, 38% of patients can actually have very good outcomes. And these are the patients that respond well to different types of treatments. They can have long-lasting symptomatic remissions. They have adequate or better than adequate quality of life. They can form families. They can even be very productive. They can work in rather complex jobs, but they represent the minority. The majority of patients with this disorder called schizophrenia have a huge unmet medical need for new and effective medications. And even the people who do well still continue to have symptoms. They're not cured and still continue to battle this disease. So I'm going to talk a little bit about the biology of the disease, and I simplified it, although to tell you the truth, there are so many different theories about what's going wrong in this disorder. And I keep on sort of flipping between disorder and disease, but fundamentally, it's very, very difficult to imagine that we're talking about one disease. So fundamentally, we're talking about some parts that people have been able to put together and some parts, large parts that people haven't been able to put together. So going back to neurotransmitters, dopamine, we know for certain, plays a huge role in this disease. Dopamine is in general one of the major neurotransmitters, and it's present throughout the brain in multiple brain areas, and it's involved in the regulation of reward and movement, or that's how people often think about dopamine. As part, and there are different dopamine pathways, so different areas in the brain where dopamine is synthesized, and different areas where it gets to be delivered by the neuronal pathways that project dopamine. And as part of specifically the reward pathway, dopamine ends up being manufactured in the nerve cell bodies in the brain area that's called ventral tegmental area, VTA. And this VTA is sitting deep, kind of deep and somewhat back in the brain, almost at the base of the brain. And from here on, it gets to be delivered to nucleus accumbens and to the frontal cortex, this big area over here that's really responsible for lots of cognitive processing that we do. And these pathways combine two pathways that I'm going to be talking about more. The motor functions of dopamine are linked to other pathways. The dopamine in those motor functions, and again, I'm simplifying what we understand today, is that dopamine is synthesized in the substantia nigra area and then gets projected to the striatum. And one of the kind of central disorders in which these pathways play a role, and that is known as a degenerative movement disorder, is Parkinson's disease. So if we were talking about Parkinson's, we would have been talking about these pathways in the brain. Okay, so going back to the dopamine pathways that are relevant for schizophrenia, we're talking about two pathways that are called mesocortical and mesolimbic pathways, and two different types of dopamine receptors. So the dopamine receptors that we're talking about in the mesolimbic pathway, and that's the pathway that goes from this ventral tegmental area, and that is that ends up in nucleus accumbens and involves sort of the limbic parts of the brain. That's is the pathway that's considered to be disinhibited, super active in schizophrenia. So it is thought, and it's been shown actually in both animal experience and with drugs that are effective in schizophrenia, the D2 type of receptors that are key to this pathway need to be blocked to be able to achieve a therapeutic effect. The other pathway, this mesocortical pathway that ends up going to the front of the cortex, is characterized by inhibition. So one is disinhibited or overly active, the other one is inhibited. That pathway, the mesocortical pathway, is actually thought to be involved in negative and particularly cognitive symptoms of schizophrenia, characterized by D1 receptors. And while we need to block D2 receptors, we also block D1 receptors, we exacerbate the disease. And that's what happens, unfortunately, particularly with the very first generation of the medications that were used to treat schizophrenia. Okay, the other neurotransmitter that I'm going to mention is serotonin. And serotonin is also a major neurotransmitter present in many brain areas. Clozapine, our most effective therapeutic agent for schizophrenia, has affinity for serotonin receptors and actually in part relies heavily on serotonergic activity, not just dopaminergic activity, and gave rise to all these serotonin theories of schizophrenia. And the multiple serotonin receptors are implicated in pathophysiology of schizophrenia. But as you can see in the diagram on the right, you have all these loops that are connecting the ventral tegmental area and the raphe nucleus where serotonin is generated, and the striatum and the nucleus accumbens. So there's interaction between dopamine, serotonin, and other neurotransmitters, and serotonin maybe is influencing synthesis of dopamine and release of dopamine. Maybe it's influencing other intracellular signals. We don't exactly know. We have some theories about the role of serotonin in schizophrenia, but they're just theories, and we haven't even been able to kind of put a simplistic picture that I showed you about D1, D2 receptors and mesolimbic and mesocortical pathways together to talk about the pathophysiology of serotonin in schizophrenia. There are other abnormalities, biological abnormalities that we see in schizophrenia and that have been shown in many studies. There are increased ventricles in schizophrenia, lateral ventricles specifically. They're the areas that are filled with fluid, with cerebrospinal fluid. There is a substantial reduction in cortical gray matter. There is reduced symmetry in the brain. And these neuroanatomical abnormalities or structural abnormalities, again, are quite well established, but unfortunately do not give us an entry into the treatment of the disease. And finally, we have at the cellular level, we have disordered cellular organization. Here you see disordered hippocampal pyramidal cells. You have a reduced number of dendritic spines and poorly functioning synapses in schizophrenia. Sometimes people think of schizophrenia as a disease of kind of mistuned synaptic activity. But all of these findings are just being studied and probably are just still opening a way for us to look at the pathophysiology of this disease. So how is it that we're able to treat the disease? We don't understand its pathophysiology, or serendipity played a major role in the discovery of antipsychotic treatments. Essentially, we got quite lucky. And luck doesn't exist by itself. So when you have serendipity, you also have to have people who are ready to note it and to use it. For example, the same thing happened with the discovery of penicillin, and in many, many cases in medicine. So the very first antipsychotic medication called chlorpromazine was synthesized in 1950 by a French pharmaceutical company, René Poulenc. And the company was developing antihistaminergic drugs for use in conditions such as nausea and allergies. And we know that these drugs are used for these indications. But a French surgeon and researcher, Henry Labrine, encouraged the company to develop an antihistamine with CNS or central nervous system effects. And as a surgeon, he was interested in treating symptoms that had to do with surgery. So he wanted to treat preoperative anxiety, and he also wanted to deal with the need to lower body temperature for surgery. But when Logovinsky started to observe the effects of chlorpromazine, he noted that it strangely induced sedation, it induced anxiolytic effects without much sedation, or some sedation, but not much. And so he thought about the fact that if you have a medication that doesn't induce that much sedation, but has these anxiolytic effects, maybe it's going to be useful in psychiatry. So he convinced two psychiatrists, again in France, Jean Delay and Pierre Deniker, to use chlorpromazine to treat inpatients, including people suffering from mania and schizophrenia. And very quickly, within a period of a year, they concluded that this medication was highly effective in treating psychotic symptoms. They published a series of reports, and that's how we came to have the first medication, which at the time, at least in the United States, was called a major tranquilizer. And that was chlorpromazine, which was marketed under the name of Thorazine. And that medication is still in use. So this was the first generation of medications that were really treating psychotic symptoms, hallucinations, delusions, the kinds of things that we talked about. But at the same time, particularly the more potent antipsychotic medications, probably exacerbating negative symptoms, and were exacerbating cognitive symptoms of schizophrenia. The term antipsychotic medication came about in the 1960s, and now we say neuroleptics, we say antipsychotics, and no longer use major tranquilizers, but these drugs do have anxiolytic and very significant anxiolytic effects. So the clozapine, the most effective medication that we have today, was part of the idea of using the serotonergic effects and effects on a variety of serotonin receptors to produce second generation of antipsychotics. So the second generation of antipsychotics were kind of trying to develop a safer clozapine. The problem with clozapine, and the reason why it remains the second line of treatment in spite of its tremendous efficacy, is that it has some very bad side effects. And the really bad side effect that it has is what's called agranulocytosis or neutropenia. And what neutropenia does is it suppresses your immune system. You don't have enough of an immunity to fight infection. You can very quickly develop fatal infection. And that becomes a huge problem for clozapine. And to this day, psychiatrists stay away from clozapine and use it mostly for treatment-resistant psychotic disorders. And so in looking for a safer clozapine, people developed this second generation of antipsychotics and relied on the dopaminergic effects, but still realized that they needed to hold on to this D2 blockade, the blockade of the dopamine type 2 receptor. Now, the first generation of antipsychotics had a variety of side effects, and the side effects that were really pronounced were what we call extrapyramidal side effects, and they included dystonia, akathisia, this very uncomfortable feeling of restlessness, wanting kind of to get out of your own skin that patients describe. Parkinsonism, after years of use, tardive dyskinesia, which involves abnormal movements, and this is something that is irreversible. Life-threatening side effect, rare but life-threatening, neuroleptic malignant syndrome. when you see, it's a real emergency in psychiatry, when you see very rigid muscles, high temperature, people can die without treatment, and hyperprolactinemia. Now, the second generation of these so-called atypical or second generation antipsychotic medications has been much less known for its extrapyramidal side effects, and it is much because of there is now less reliance on dopamine D2 blockade and more of a serotonin effect. But there is a metabolic syndrome, metabolic side effects associated with these drugs. They include weight gain. Um, uh, uh, they include increases in blood glucose, leading eventually to diabetes, lipid abnormalities, leading to cardiovascular diseases, to stroke. And so they're associated with a variety of their own side effects. So we have produced drugs that arguably are safer than the first generation, likely are better tolerated than the first generation, but still leave a huge need for newer medicines in schizophrenia. And it's particularly so, again, because while the second generation of drugs, including clozapine, these are typical antipsychotics, do have some effect on negative symptoms and cognitive symptoms of schizophrenia. They leave a lot to be desired. And so our big need is in trying to deal with negative symptoms and particularly cognitive deficits in schizophrenia. And that's an incredibly challenging task. Almost every major neurotransmitter in the brain has been manipulated toward improving cognition in schizophrenia. And all these attempts have failed so far. So that remains to be a huge need and a huge challenge for us. So in summary, schizophrenia is a biological disorder, and more likely it's a spectrum of disorders with complex genetic and environmental interactions. The pathophysiology remains unknown. We've made some progress, but we need to continue to make progress and to understand better the pathophysiology, both at the level of neurocircuitry and at the level of biochemistry or neurochemistry involved. Several generations of effective treatments have been developed for psychotic symptoms, but as I told you, there's a huge unmet medical need. Current biological research uses genetic, neuroanatomical, neurofunctional, and molecular approaches to study schizophrenia. A variety of other interventions have been very helpful. One of our really helpful treatments continues to be ECT. So when one can't deal with psychotic symptoms in patients with medications, ECT is still used. And as we continue to learn about the brain and our understanding of how the brain functions, I'm sure we'll continue to understand the pathophysiological underpinnings of schizophrenia and understand better the disease and develop drugs in a much more rational way. Again, the way that Dr. Luthman was talking about this morning. So thanks very much for listening.
Thank you so much. And everyone, please give a very warm round of physical or Zoom virtual applause. Thank you so much for the wonderful, detailed presentation. I think I can see all of the neuroscience students in the room smiling because we really love to hear about an in-depth overview of schizophrenia, especially drawing from your professional expertise. With that being said, we'd love to open up to questions from the audience. Everyone, if you feel comfortable typing in the chat, or I also enabled the unmute option, whichever means you'd like to share a question, please feel free to do so. And I know it can take a few seconds to wrap your thoughts together. So Dr. Logovinsky, I'd like to start off with a question for you. As you detailed in your presentation, there's a lot that we still don't know about schizophrenia, there's also a lot of information that is misunderstood. And I was really curious to ask, do you find any current misconceptions that are present within current research or therapy approaches or clinical practices that are really affecting the way that our understanding is translating to patients?
Among researchers, it's hard for me to talk about misconceptions. Among the general public, there is this fear of schizophrenia. And I just want to say that the biggest danger that these patients represent are to themselves and to committing suicide or harming themselves. And those few people who actually become aggressive are few and far between. In the research world, what we're dealing with are not misconceptions, but the complexities of the science and the complexities of the neurobiology. And that's where we find ourselves very often. And you can imagine how difficult it is to talk about animal models of schizophrenia. Animals don't have schizophrenia. And so when we experiment on our drugs, first, we have to induce behavior in animals that somewhat resemble the behaviors and the deficits of schizophrenia. And that's a huge challenge. So are there misconceptions? I would describe them as challenges.
Thank you. Definitely, that makes a lot of sense. And also touching upon what you were saying about how among individuals who are affected by the condition, there's a lot of stigma, misunderstanding. How do you find that kind of negative portrayals of the condition in the media, in TV shows and movies, all these representations, let's say, maybe affect the way that patients come to seek help? You mentioned that they may be more likely to commit suicide or have ideation. What are kind of the missing steps, let's say, in the link to patients seeking help?
So you could imagine, first of all, that these patients are very ill. They have intolerable symptoms, and they can't take some sort of a medication that would take their pain away. They're constantly living with it, right? And those people who function better and who function at a higher level, they unfortunately have to hide the fact very often that they have schizophrenia. Imagine a coworker or imagine a fellow student who would have told you that he or she has been diagnosed with schizophrenia. Imagine the stigma associated with that. And then the other problem is the nature of the disease. Maybe the most persistent delusion or delusions, the type of delusions that we have a very hard time dealing with is paranoia. There's something about paranoia that's so deeply built into our brains that it's very hard for us to correct for it. Now you have patients who understand well enough that they're on the outskirts of society. Plus, they have this internal paranoia, this fear of people, including physicians, who come close to them. And that creates a huge problem. Plus, when they start to take these medications, they have very unpleasant side effects. So they want to discontinue these medicines. So there are huge psychosocial problems that we're dealing with in this realm. And that represents another challenge for us.
Thank you so much for sharing. Yeah, I think just from what we're hearing about, describing to us today, it seems like there's so many different factors and dimensions intersecting, and shifting a little bit from the psychosocial to going back to more the molecular level. Bertina has a question. Are the drugs you described in the fight against schizophrenia also being used to treat any other illnesses?
Very frequently so. And that's where I started with, right? When you have other illnesses that involve psychotic symptoms, you start using the same medications. So the first line of medications are used in a variety of conditions. And they're certainly used in all those conditions that end up having a psychotic element. So, for example, in bipolar mania or psychotic depression, the same drugs are used. And then sometimes you use these drugs for in much smaller doses um, to treat very persistent anxiety. Sometimes you treat attenuated symptoms in a variety of other disorders. But definitely these drugs are used outside of schizophrenia. They carry a black label, meaning a huge warning for the use in the elderly, and particularly the elderly with dementia. Dementia, such as Alzheimer's dementia, Parkinson's dementia, Lewy body dementia, all of these are associated with psychotic symptoms as well as disease progresses. And the antipsychotic medications are risky for these patients because they can cause sudden death, and but they still end up being used in these populations.
Thank you for sharing that. It's really interesting to hear about, especially in terms of population demographics and in aging groups as well. We have a question from another audience member, Surastri. Do you think that new technologies like nanotechnology could be promising in creating treatments that are less heavy-handed in shutting down the dopamine pathway that you mentioned?
I think that the newer technologies are going to help us with understanding the underlying biology better. And in that sense, they will lead to advancements in treatment. But we're not talking about diseases where we can identify genes that we can switch in and out. We're talking about a much more complicated situation here. The other thing that is going to become very important for us is the use of technologies that rely on processing tremendous amount of information and putting that information together and recognizing sort of how to put the information together. Because so far, we have a rather fractured understanding of the neurobiology of the brain, meaning that we'll look at different pathways, we'll look at different neurobiology and neurochemistry, but it's hard for us to put all of this together. And hopefully, things like information processing is going to help us a great deal in just putting the information together and creating a conceptual framework that would unite neurobiology much better than it is united today.
Thank you so much. That was really, really great to hear about. And with that, it seems that we've reached the end of our Q&A. So I want to thank you so much once again, Dr. Logovinsky, for taking the time to be here with us today. Thank you everyone for joining us today. This is actually the concluding session of our first day of the conference. So please join us again tomorrow afternoon, maybe morning, depending on where you are, for another very exciting day of listening to amazing professionals and advocates and individuals in the field who are going to share about their experiences. Thank you so much once again, and have a great rest of your evening, everyone.
Thank you very much. Thanks for the invitation and for listening.
Thank you. Bye-bye.